Okay, I just couldn't see as the screen was moving. Thank you very much. Thank you. Um, Welcome everybody to our QEI showcase in 1st of January. First of all, we have Natalie Fox with us. Would you like to say a few words, Natalie?
Just want to say welcome everyone. Great to see again so many of you on the call. Interested to hear about what some of our colleagues are doing across the organisation around their quality improvement projects and just the continuous improvement work that seems to be getting better and better across the organisation. So just really interested to hear what's been going on, but it's great to see so many of us. But I will give a little plug. Obviously, we're the interested members of the organisation. So where you can, please do talk to members of your team, other staff members, because it'd be really good that we got more staff on to hear about what's going on across the organisation, because you're all doing some great work. But just to say a big thank you, and over to you, Alison.
Thanks, Natalie. Just to say, we are on social media. So there's a QR code there, both for our microsite, where you will find all sorts of tools, events, the training, etc. So do please take a look at that. And also we are on LinkedIn. And again, the QR code is there. So please feel free to post anything that, especially about our QI showcase today. So thank you. On the agenda today, we have two projects that have been done across the organisation. First one with Mital Amin is the increasing the appropriacy of referrals made to the Camden and Islington Care Home liaison teams. And the second is about a menopause pathway with learning disabilities in the Enfield division, which is with Tamina. So I won't say anything more about them, but thank you so much. And this is a great opportunity for you to share your work. So shall I hand over to you, Mital?
Hi, thank you. Sean, are you going to be moving the slides along? Perfect, thanks. So my name's Mitchell. I'm an OT. I cover Camden and Islington. In total, I cover probably about 13 homes. We're a very small team, so we're made up of one psychologist who I think she's got 2.5 days across the two teams. We've got a consultant cover 1 day a week. There's an assistant psychologist who does, I think, 1.5 days over the two teams, and there's nursing cover for 5 days. And there's also one other OT who covers 2 homes in Islington. So I myself, I work with a lot of residents who have a form of dementia and what staff describe as behaviours that challenge them. This could be during sort of personal care, poor night routine, aggression, restlessness, wandering, etc. I've been working this post for nearly 3.5 years now, if not slightly more. And I guess this project I've put together, it's based on sort of a number of observations, discussions that I've had both in our team, but also whilst in some of these care homes. So the project focused on increasing the appropriacy of referrals made to the Camden and Islington care home liaison teams. We were receiving a high volume of sort of incomplete or poor quality referrals. So by that, it's, sections were being left blank. It was lacking relevant information. There was bits where it was saying there's no risk present, but, there'll be safeguarding concerns open, or, someone's been taken to A&E because they got into a fight. They're failing to actually state an issue or even a goal of what staff were actually looking for. It could be things like the GP said to make a referral, but we were none the wiser on what the referral wanted. Often referrals also received were inappropriate, such as sort of residents having infections, skin wounds, issues with sort of oral intake. And these referrals are sort of better suited for other services such as GP, dietetics, district nurses, SALT, and sort of social care. Equally, we were receiving referrals for those who had only been in the home for a few days or a week or so. Usually there's a settling in period, particularly for those with sort of moderate to advanced dementia. It can take a bit longer. So as a result, we were spending a lot of time contacting sort of referring individuals to ascertain further information on what staff were actually seeking. but also whether the referral was appropriate for us or whether staff needed to sort of rule out physical health causes or simply just allow the residents some time to settle and, staff to get to know their residents. I found through discussions with staff, they were not always aware of who to contact or confident enough to ask the appropriate questions to seek support when needing support. So the aims of the projects was twofold. So first one was to increase the number of appropriate referrals to our service. So this is referrals accepted with us having to follow it up, seek clarification. We wanted to increase it from 75% to hopefully about 85%. And then the second goal was improve poor quality referrals by 20% over a 6-month period. So like I said, just having a bit more information there for us. Next slide, please. So understanding the problem, understanding the problem helped to identify, the solution. So discussions were held with care staff making referrals, as well as management within a number of homes across both Camden and Islington. Initial discussions explored whether staff would like support to better understand presentation of their residents, when to seek support from services, but also who to refer to. But also if they were making a referral to our service, how to refer to us. We explored whether a visual representation in the form of a flowchart would be of benefit, so staff had something to refer to when making referrals at later stages. We explored whether training would help staff understand presentations. Some of the key themes highlighted by staff, during our discussions were they wanted something to refer to, wanting to know how to get support quickly. Staff were saying if a resident's really aggressive, they've made a referral to us, but we're not coming out quickly enough, or they're not getting that support that they need quickly enough. What to do when residents presented in a certain manner and understand what that means, but also how to refer. One of the newer members of staff that I had a conversation with said to me he wasn't really sure what information to write in the referral form, just because different services seek different information. So follow those conversations with agreement. I offered a range of dates and times to sort of management in the home. I ensured this was outside medication rounds, but also meal times. I did that particularly just to ensure there was some protected time for staff to be able to attend. Next slide, please. So the QI project itself was set up in one care home in Islington. It ran between December 20th, 24 until July 31st. This home was chosen due to the volume of poor quality referrals we were receiving, as well as the number of inappropriate referrals their staff were making to us. The three main drivers to support staff looked at sort of staff willingness to engage, explored what would be of benefit, what was needed by staff, that they are willing to take on board and use, but also management support was a big aspect. So it's just ensuring that support was there top down. Looking to address staff knowledge and understanding. So this was, in a form of training, having visual and verbal guidance to help staff understand various presentation types, as well as influencing factors, but also learning about service users that may support other services that would better support the residents rather than care home liaison in relation to, for example, poor oral intake and weight loss, for example. Staff confidence and knowledge. So for this one, it was understanding how to make referrals, what information to put down, having the opportunity for staff to actually ask questions if they're not sure, having that visual guidance for them to refer to, taking them through our referral form, what it looks like, what sort of information we would expect in various sections, and also offering that follow-up at later stages. Was this okay? Was it okay to fill in the referral form? Is there anything else you'd like offered in the sort of training that's been offered? The flowchart itself was developed as a visual aid to help empower staff to access appropriate services in a timely manner. And it was solely to help through staff understanding their residents' presentation. The flowchart itself helps staff understand the presentation in an acute or a gradual manner. So what to consider for each presentation type. So for example, if an acute presentation could be things like a UTI, this is very sudden, you'll see very sort of specific behaviours pop up, and interventions for this sort of a presentation would most likely involve antibiotics, which is better suited to a GP. A gradual presentation type could involve a slow withdrawal from others, not wanting to leave the individual's room. This could have happened after an incident in one of the communal areas. There could be fear, there could be anxiety. And this may require more specialist graded work, which is something more better suited for us. The training, for example, was an hour long, and all of the examples were offered, and it's broken down. It's a very sort of user friendly. There's colours, there's sort of arrows flowing through. Each section has sort of little guidance and prompts. Have you considered? And it's just taking staff through that flow chart, and then also taking staff through our referral form, how to fill it in. Again, offering that opportunity for staff to ask questions. There have been reviews and follow-ups with staff. So whenever I go back in, I will check in with staff, ask if everything's okay. Is there anything else they would like support with? Generally, feedback's been positive. I've not so far had any recommendations for improvement, but I don't know if that's staff being nice or whether the training was appropriate. So following this first care home, I've since offered this the flowchart to 2 other homes. I'm also due to offer it in another home in, I think it's the next fortnight. Each time I'm generally asking for feedback. I'm asking for feedback at the end of training. I will also check in with staff when I'm back in the home. The overall aim is to offer it to all homes under our service across both boroughs. Go next slide, please. So looking at the data from the original home, over a 1-year period, we received 27 referrals prior to the project. So of the 27, 15 referrals, or 56%, required a follow-up for clarification on issues. Of those 27, 22 or 81% were eventually accepted once we knew what the referral was asking us. And that could be things like follow-up phone calls, emails, or just conversations when we're in the home. Of the 27, 5 or 19%, that's nearly 20%, were rejected just because they were inappropriate. It was not for us. Another service or support was required. Looking at the referral quality, so we measured this out of 10. 12 or 44% were rated as poor quality. So this is a referral that might score between 1 and 4. At the poor quality referral is generally missing information. They're not really stating the problem. It's highlighting physical health concerns, but there's no medical follow-up. There's no information on risk, or somebody's just moved in, but there's no issue. So it could be, someone's just moved in. There's a history of depression, that sort of thing. 13 or 48% were rated as medium quality, and generally that's between sort of the scoring of 5 to a 7. Some information is missing. It may not always state the problem. There may be some sort of physical health concerns, or again, someone just newly moved in, but there might be a few more concerns that need follow up. 2 or 7% scored 8, or more, which is good quality. Most, if not all, the information we require is there. We don't have to follow it up. We've seen the referral. Yep, this is perfect. We'll go out to see the person. After the project, referrals dropped to 7 over 6 months. So this, if you look at it over the whole year with the forecast, it's less than half of what we received the year before. So one of the 7, so 14%, required a follow-up, just what questions we needed to ask. Of the 7, 100% were accepted. So they were all appropriate for us. So no referrals were rejected. Of the 7, we had no poor quality referrals. We had 6 medium quality referrals, which was 86%. And we had 1 good quality, which was 14%. So looking back at the sort of initial aims of this project, they were both met. We had no poor quality referrals. The aim was to kind of increase it by 20%, but we didn't have any, so we fully met that one. And the appropriacy of referrals were 100%. So again, that goal was met as well. Factors I did notice post the project and as well as whilst it's going on. So of the 7, we had 1 that did require a follow-up. And I noted it could be due to various factors. It's looking at staff turnover. New staff may not have the knowledge to complete the form. Staff who had not attended training. That 1 referral was made by a member of staff who had attended. And communication between staff following training. So although the staff attending may now make really good referrals, that knowledge they've developed and they've attained through that training hasn't been passed on to their colleagues. So newer staff or less experienced staff are still making sort of referrals that we do have to follow up from time to time. Last slide, please. So plan to kind of sustain this improvement. So based on those sort of factors I've highlighted, regular reviews with staff and check-ins. So it's looking at whether staff need support or sort of follow-up. It's offering feedback to staff when we do receive some of the poorer quality referrals. So, offering sort of a nice sort of a nudge, how that referral can be improved, what sort of information can be put on. But I've also offered a refresher session, so particularly to that home, because we've had 2 or 3 in a short space of time, because they've had a high turnover of staff. So it's great for the staff that stay put, but for those that move, we are having to kind of offer some follow on. Looking at future direction, so our aim is to offer this to all the homes across the 2 boroughs. So it's at the end of this month will be 4 homes. So I've still got like another 8 to go, 8 or 9. My maths is not great right now. But it's, looking to see what sort of further support is required each time I do it. But so far it's been good. Looking at potential sharing, Care Home Liaison is the only team in the 2 boroughs, but we could look at what other services may benefit within the partnership. Although this flowchart has been developed for older adults within a care setting, we could explore use in a similar setting for other age groups, such as learning disability. Looking to liaise with colleagues in neighbouring boroughs as well as the partnership. I have discussed the flowchart with colleagues with similar services in the partnership, but also I've spoken to OTs in sort of our neighbouring trusts just to see if something like this could be of benefit to them. And lastly, we do have a Margaret Butterworth Forum. So this is a sort of the regular showcasing of research completed by professionals working across the UK in the care home setting. So that is sort of a long-term goal for me, not at this stage, but it could be something that I could also explore just to show it does work. Because, working with care homes across, nationwide, I'm sure it's a common theme. And that's me done. Thank you.
Thank you so much, Mital. A really good presentation, very clear, and it just shows, some relatively small changes. I know that they probably didn't feel like that at the time, but some relatively small changes have made a difference. And, the service users especially probably getting more timely care as a result. So thank you very much. Does anybody have any questions at all? Any observations? Okay, who have we got? Let me just hang on. People, the hands went up so quickly. Carol.
I just had a comment. I'm OT in the Barnet community, and I wanted to come along today because I'm resurrecting my QI project. So just to say you're giving me inspiration, and how you've laid some of it out would be helpful for my project. So thanks. And it's good to know that some of those small changes has made such a big difference. So that was great to hear.
And that's a really welcome feedback there, Carol, because this is the whole idea of these sessions, that others absolutely learn. And it's great to hear that you've been inspired. So thank you for that. Mark Pritchard.
Yeah, thanks, Matal. And I thought it was really a really good piece of work, well presented. And I think particularly across our older adults and rehab care group, I think the learning from that across the wider care home provision, we certainly want to share and spread that good practice. And I think just I was really pleased to see you highlighting visual aids as well, because you have flagged turnover of staff. And I think having that visual aid just allows us to keep that continuity of the pathway as well. So really, well done.
Thank you, Mark. Did you want to say something, Mital?
The only thing is I didn't actually put my flowchart in, but if anyone would like to see it, because it's a big A3 size poster, I'm happy to send that out as well.
That's great. We're happy if you want us to circulate it to everybody who here, and also we can add it to the microsite with the copy of your project, Natal. So therefore, it's available for people to see. Thank you, Erasmo.
Hi, thank you. Thank you, Mital, for your really great project in the way you've evidenced the use of a referral process within a QI methodology. And as Mark highlighted, it's great for older adults, but great across other specialities in terms of the usefulness of a referral form. I suppose what I'm really curious about is it's clear that they help, and what I've always felt with referrers, because they're from different systems and different people in different systems, some are new, some have a need to learn about different services, that it's herding cats. I've always said that one can never assume once it's clear everyone's going to know how to refer. So it's great that alongside the referral form you've done training, and there's kind of an aid memoir to support the thinking. I think what's interesting is I've always the crux of what I'm thinking about is that there's always an issue with the referrer maybe thinking this is extra work I have to now do, and yet the irony is, but you can't just refer without much information and expect the recipient team to do the work when it might not be appropriate. So it's just so important that the evidence is a good referral form, reduces time along the care pathway, and is a really valuable thing to do. So I think it's really great you've evidenced that, and it's great to see the different data you've used. So I think for other settings, I've heard challenges with people not wanting a referral form, but sometimes it's the most optimal thing to do. It's not constraining. There's work, whether it's for the referrer or the receiver, but it's better that it's done clear at the start. And if we think about waiting times, a good referral form will solve a lot of extra inappropriate work down the line. So it's great you've evidenced this. It's really good. Thank you very much.
Thanks, Erasmo. And Susie.
Hi, thank you. I'm Susie Willis, one of the AHP leads. So Mital, I'm really delighted to see you here today, and thank you for a fantastic presentation. Very well done and delivered. Just following on from Erasmo's comments and thoughts, what struck me was that the number of referrals that you received following the training reduced dramatically, but that they were all appropriate and very well completed. So it made me think there's something about filling out the form and providing you with the information that's required, but there was also something there in the training, perhaps about what your team offered, and the care home knowing exactly what they were, who they were referring to, and why. Would you concur with that part of the training was informing the team about the service that you provide, so that they would make an appropriate referral on that?
Yeah. Initially, it was just the flow charts looking at, but also if you look at our referral forms, they were so poorly done. So I kind of made it twofold. But I agree, it absolutely made a difference when they understood what we can and can't do versus here's a service that would come out quicker than us to deal with this one issue that you're telling us about.
Yeah, because I think that happens a lot for all disciplines. I know that, quite often an MDT will think we need an OT here, perhaps, so we'll just ask for an ADL assessment. And actually that's a sort of catch-all for occupational therapy. They know that there's something going on, but they're not quite sure what it is. So informing people about what we are and who we are and what we do, I think is just as important in the referral process. But thank you.
Thank you so much, everyone, for all your questions and comments, and Mital for an excellent presentation. So thank you for that. And I think we've heard today that, this could be scaled up to other services as well. Not just services such as yours, but, the whole ideas behind it used in some of our other teams. So it'd be really good to hear in the future whether that has happened. And you've already said you've been in contact with various teams. So I'd love to hear later on, in a couple of months or so, how that's going. So thank you, Mital. Shall we, Tamina? I can see you there on the screen. So welcome, Tamina. So now quite a different project, but this is looking at the Learning Disabilities Service menopause pathway. So thank you very much for coming, and I'll hand over to you.
Thank you. For my QI project, it was a project related with developing a menopause pathway for our integrated learning disability service, which is in Enfield. And just to give a background, I am a clinical psychologist and I work in an integrated learning disability team for the last 4.5 years almost. We work together alongside with other disciplines, and when we are developing some project, we bring in all the disciplines in so that we get all kind of perspective in, and it's a kind of a wholesome kind of care that we are providing to our clients. On this project, I had myself, one of the community nurses, a psychiatrist, and 2 of the trainees, clinical psychologists, who I always mention because they have done really hard work on this, and they have left now the service and gone to their placements next ones. So they have done a really good job on this. Having said that, when we talk about learning disabilities, just to give a background to other people who have lesser understanding or maybe have not experience of working with people with learning disability, in UK, we have around 1.5 million people who are diagnosed with learning disability, and 1.3 are residing in England, having all that health inequalities, and despite of wanting to live fuller life, that makes like 2.16% of adults. And our team is also dealing with people with learning disability in their adulthood. In Enfield, only there are 1,500 to 1,600 clients that are on our caseloads, on our registers, that are registered on learning disability as having learning disability. And that is, while working over here, we identified that there is a lack of knowledge amongst women with learning disability and their carers about symptoms and signs of menopause. Women are referred for symptoms such as cognitive decline, agitation, and anxiety, whereby menopause is currently not considered by the referrer. So some people present a similar presentation, for example, in presentation to dementia, or even having vitamin D or iron deficiency can also have the same impact as brain fog, low mood, and chronic fatigue. So now what we have done is that in our dementia pathway, we are including the menopause symptoms to be eradicated before the DMG assessment is going to take on. One of the thing is that when we were talking with parents and carers about the signs and symptoms of menopause for women with learning disability, there was a shock response that we used to get about like, oh, nobody actually considered that people of learning disability go through the same kind of stages throughout their life. This was something that raised our concern about not providing that system. So we thought that developing a menopause service will be a really good idea for updating their knowledge and making sure that we are providing the care from all aspects as well. The smart aim was to develop a menopause pathway for women with learning disability between the age of 35 to 55 years of age, and their carers, families, professional staff in Enfield division. And that was that we aim to finish it by 31st of December. And it started on 7th of May last year. Thank you. So one of the main aim was to how we are going to provide the service users with the knowledge. So we arrange workshops for our service users only, and we gathered their feedback before and after the workshop, and there was a significant increase in their knowledge. knowledge about symptoms and identifying the stages of menopause where they are, and on ways of treatment that were there. They were all, some of them were already aware of those, that what are the treatments that they go, but they were quite not aware of that, the list of the entire list of symptoms. We also explore their feelings and their thoughts about menopause during those workshops, which was quite helpful to gather that data. We also informed to acknowledge, like to develop the knowledge of carers and families. We also arranged a workshop for the carers and families, but unfortunately, nobody actually attended. And we offered that to our staff, because one of the secondary aim was that we are going to train our professionals as well, alongside with carers and family. So the carers, the staff also, we explored the understanding and identifying the system, because when they are working with their clients, they will be able to see that. Having said that, we've got a large number of people who falls into the age of 35 to 55, is around 135 females that we have. So a lot of other disciplines are working with them, and we will be this pathway is going to make them aware of, like, being aware of the symptoms and refer it to us when it's the right time. Can I have the next slide, please? Thank you. That's our driver diagram, and I'm pretty sure nobody can read it, so I'll do it for you guys. The primary drivers was to improve the knowledge and awareness of the service users, and how it was done. It was by educating sessions for the service users, like the workshop that we have done, and easy read menopause information. So there is a lot of easy read information that is present on internet, but we had the privilege of having an easy read group that was already running in our service. So we took all those easy read leaflets and informations that we have to that group, and we did a lot of co-production where the trainees role came in. They did a lot of co-production work, going through each and every documents with them every week and making sure that the most appropriate was identified. Some of them were developed by that easy read group, which was very helpful. The secondary driver was to improve carers and support. We did the presentations, and we did run the workshop, which didn't work, and that was our next our PDSA cycle, which I'll come back in a minute. To improve professionals' awareness, that was also part of it. So trainings and workshop and shadowing opportunities, especially when we were doing the screenings, that is still going on. The second primary driver was to improve education or detection process, basically. So that included menopause symptoms monitoring by both service users and the carers, and prompts in the protocols that we already have, that any of the assessments that are happening over here. We didn't created the checklist for the symptoms. It was already like Devon Partnership Trust already had that was very comprehensive, so we are still using that. We displayed posters and leaflets in the waiting room. We sent it around in the GPs, so it was shared amongst the GPs in our area, in our borough. Prompts in protocol, we are considering in all kind of like, for example, behavior of concern assessments, psychology and psychiatry assessments. We have prompts on the electronic record, and also with GPs. Including this assessment to be done in their annual health check. Third primary driver was to improve access to treatment. So a lot of information about menopause treatment was also offered. We created accessible information about HRT, which is the hormonal replacement treatment. Patients going GPs are also identifying these, because they are prompted by our service. And we are also asking carers to book a screening for their client if they are concerned about it. service users are offered menopause treatment. It could be there is a direct route of like CRT referrals that comes in through to us, and we've got the pathway running. Our community nursing are screening them, and if there is a need about the psychoeducation, they will be referred to our psychology team, where we will be considering doing some kind of psychoeducation work with our client. The PDSA cycle was we were having we were struggling in involving the carers. The thing was that when we investigated why the carers were not coming, one of the things that came up was they were not paid for attending an event or a workshop, whilst they were not working with the service users. And it was across the whole invitation slot that we have, that we thought that it will be helpful for them to understand. But we then developed a menopause coffee morning type of workshop, which we included. We invited both carers and the service users, and then they noticed that there was an increase in number of carers attending. And now to improve it further, we have decided that we are going to take this workshop and coffee mornings to the care homes or to the provider cares and record the first session, make it available for all the staff for revisiting whenever this is needed. And this is ongoing. We are still working on that. Other ideas that we have when it comes, a lot is coming in when we are doing service users workshop. Some of the service users saying that, oh, this is not for me, or I'm not, I'm okay in that term. So not realizing that this stage is approaching, and due to denial or other ambitions, we are making sure that we are providing them with accessible information and improving their awareness. Carers and families are also being made aware and prompted in every assessment that within our team to encourage questions related to menopause. Can I have next slide, please? Thank you. So I've already gone through some of those things, that there were struggles with carers involvement. When we did the menopause coffee morning, we gathered the data before and after from each carers and the service users, and they were quite positive about having more understanding of menopause, and they feel more confident about identifying the symptoms of menopause. This is something that is going to carry on, and we will be monitoring it closely, how we are going to develop and increase the knowledge across using not only the families but also the providers, the care home or providers, and we have a number of providers on our list which we are actually targeting, because we think that they have the appropriate the client group that we are talking about. Can I have the next slide, please? Thank you. Having said that, this is the next step. To increase the knowledge, we are taking it to the carers. We are in close contact with our GPs, where we are conducting, we are prompting them to add the screening to an annual health check. And this is going to be closely monitored by the community nurses. We have shared the entire slot of our easy rate documents. It is also available for everyone. If they need, we are happy to share it across the trust. And it is going to be shared with the care providers and signposted the pathway to get support as much as possible. There will be a lot of attending in future. We are running it every 2 months. A workshop will be there, and we've got an MDT MDT meeting that is arranged for every 6 weeks. That is already happening, where we discuss the referrals that we are getting in and how we are going to provide them with the care. So I have shared this project previously as well, and I'm aiming to develop a kind of a liaison network around with other boroughs as well, who have the same pathway already established or they are trying to establish. this point. And that's it.
Thank you so much, Tamina. Such an important and issue for sort of women everywhere, but particularly with those with learning disabilities. So a great project, and thank you for coming today. Very well presented. Thank you very much. Does anybody have any questions, comments? Mark.
Yeah, thanks. I mean, it's really good to see today's session because we've had two really good presentations from services within the older adult and rehab care group, which incorporates LD. It was really just a question because across all of the other LD services we've got within the trust, I just wanted to check whether you've already had those links, because it's some really excellent work here and we want to make sure that this is shared across the other LD services.
Yeah, so Camden and Islington already have their one menopause pathway developed. So we were working with them, getting the guidance from them as well, that what helped and what didn't work before we started this project. So we have got plans in future to liaise with other boroughs as well, to find them, either to help them develop a pathway if it is not there, and have a separate team for that, to share the resources that we have developed.
Thank you.
Thank you.
Thanks, Mark. Sifi?
I just wanted to recognise the service user and carer involvement here. And Tamina, you've done a great job of kind of using that PDSA cycle to really understand what got in the way of carers being able to attend your workshops, and, you know, really turning that and using the PDSA cycles to then take those coffee mornings to them and, you know, making it really work. And that's really helped with your attendance. I just wanted to recognise, you know, the importance of service user and carer involvement. And this is a really great example of kind of using PDSA cycles to, you know, learn from their feedback and making a success of your project. So well done.
Thank you.
Thank you, Sifi. Vincent?
That's a comment really. To me, I think this is a brilliant example of showing how you can use QI to address inequalities. Because, oh my goodness, people with learning disabilities suffer so many inequalities, and people going through menopause also suffer inequalities. So this is just an absolutely brilliant piece of work. So well done. And I do think this is work which is kind of leading in the organisation. I don't see this happening in many of our other services. So yes, so others on the call, please think about this in your services and how we support people. So yeah, congratulations, well done.
Thank you.
Thanks, Vincent. That's a great point about inequalities. So thank you very much. Anybody else have any comments? No? I think we've seen today. Do you want to take the slides down, Sean? Thank you. I think we've seen today two great projects that have happened within our organisation, examples of QI work that is going on. And this provides such an excellent opportunity for people to showcase their work, but also it's so important for us to be able to learn and spread as well, but also scale up. So we've heard today absolutely two examples that their ideas could be scaled up across the organisation to benefit other service users. So I would please ask, as Natalie suggested at the beginning, that you all spread the word about people attending this, and especially those who perhaps want to get ideas, etc. So I do thank you all for attending. It's been excellent to hear the projects, and we will make sure that we add them to the QI microsite so that they are available for everybody to see. Does anybody else have any further comments or questions that they want to raise before I close today? No? Thank you so much, and we look forward to the next one. Thank you.